Good afternoon, everybody. Please, who can have a seat? Before we start, I wish to thank all of you for coming here to support your daughter. I see the people who are here. I think she's a princess. Princess, you are going to NWANA. You are going to show us that you are doing princess today, right? Yes. Okay. The exercise today is exercise. One of the last exercises that she's going to do in this program today. And she has to present something to show that she studied here in the form of a research. I will try to ask everybody to, in the course of the presentation, to off their phones so there will be no distraction to her. It is very, very important. And then I'm also going to present the members of this jury. After her presentation, Nico will give us some few moments for us to get grades, and then from there we'll present the final results. The jury, the members of the jury, we have two powerful members of the jury here. One on my right is my elder brother and friend, senior colleague, Professor Simon Gamifeu. He's the one who worked with her on this work, supervise her work. And he's going to defend her work also to give us more light on how the work was carried out. On my left, I have Mr. Merkaide. He's coming out of Cameroon just for this thesis. And we're privileged to have him here. I think he's going to examine this work, and then from the judgment of his examination, you are going to validate the work or not. My humble self, I am Professor Abu Michael. I'm also a lecturer in this university as Professor Phil. I am privileged to be in this jury with my senior brother. Actually, I'm not supposed to be in the jury where he's there because he's more elderly than me in the profession. Yes, I'm privileged to be in this jury, to preside this jury. So here, I am just like the judge. What he will say and what he will also say, there I will be here to moderate the two. NWANA, Hilary, is there any person in this jury that you don't want to be part of the jury?
No, sir.
Okay, I'm glad to hear that. There's no light. I'm sure there's no light. That will not stop us from progressing. The only problem is that we will not be able to see the pictures that you present because I saw many pictures. There's light. Is it working? Okay, it's working. Are you ready?
Yes, sir.
Are you stressed? No, before you start, just take some water. Please just cool down a little. So that your voice can come out very well. You're from Welcome?
Pini, sir.
Pini? That's the lab?
About it.
Okay, please, the floor is yours. You can start presenting.
Thank you, Mr. President of the jury, for letting me have the floor. Mr. President of the jury, honorable members of the jury, distinguished guests, welcome and good morning. The dissertation which we have the honor to present to you is titled Contribution of SGG MK 1.0 by NWANA in the care of patients suffering from knee stiffness at Lakentini Hospital in Douala. It will be presented to you according to the following plan. After a brief introduction from which our research question will arise, we will see in detail the objective to be attained, the methodology used, the results which we will simultaneously discuss, and we will end with a conclusion, recommendations, and a summary in French. By way of introduction, we can say that knee stiffness is a feeling of tightness when attempting to move the knee after a period of inactivity or the inability to do more than 90 degrees of flexion, because a healthy knee is one which can flex at 120 to 140 degrees actively and 150 degrees passively. There are several causes of knee stiffness, such as trauma, osteoarthritis, gout, and then the build of physical therapy. But for this presentation, we are going to focus on knee stiffness caused by prolonged immobilization and knee stiffness due to knee stiffness as a post-operative surgery. A study carried out by Musab and Associates in 2021 revealed that the incidence of knee stiffness is 64.7 in patients after knee surgery. And knee stiffness is also present in 4 to 16% of patients after knee arthroplasty. Now, what does medicine propose? Medicine proposes manipulation under anesthesia, chiropractic, surgery, non-steroidal anti-inflammatory drugs, and physical therapy. And when doing physical therapy, we can use assistive technology. And assistive technology is any technology or material used to help people with disability, which gives us our next definition, SGG MK 1.0 by NWANA. SGG MK 1.0 by NWANA is a wooden assistive technology designed by myself, NWANA Hilary, and Associates for rehabilitation of patients suffering from knee stiffness by positioning and continuous passive mobilization. It will be used by patients according to his or her pain tolerance. The interest of our study was to know how this instrument can contribute to the rehabilitation process of people suffering from knee stiffness. Based on this observation, we asked ourselves the following question. What is the contribution of SGG MK 1.0 in the management of patients suffering from knee stiffness at Lakentini Hospital in Douala? We set a general objective, which was to evaluate the therapeutic effect of including a mobilization instrument in the rehabilitation process of patients with knee stiffness. Then we set two specific objectives, which were to identify cases of knee stiffness following prolonged immobilization or surgery during the study period and present the result of the use of SGG MK 1.0 and conventional physical therapy methods in patients suffering from knee stiffness at Lakentini Hospital in Douala. To attain our objectives, we employed the following methodology. We conducted a descriptive study carried out at Lakentini Hospital, Douala, over a period of 2 months, ranging from June to August 2023, and our study population was all patients suffering from knee stiffness after surgery or due to prolonged immobilization. We included conscient adults with knee stiffness of immobilization or surgery and were at least 1.60 meters tall, and the cause of the stiffness must not be more than 1 month old. We excluded patients who presented osteoporotic bones, signs of venous thrombosis, had signs of a herniated disc, sensation disorders, and open bones. We did a non-probabilistic of convenience sampling, and the materials we used the SGG Mobile Knee 1.0, a measuring tape, a visual analog scale, gloves, and a monitoring sheet. Honorable members of the jury, feel free to palpate and see the instruments which we used for our study. As variables, we had as sociodemographic variables, we had age. As anthropometric variables, we had height. And as clinical variables, we had scar, pain, and knee range of motion, specifically flexion. To carry out this study, first of all, we had our protocol validated by the Higher Institute of Health Science of Université de Montagne. Then we obtained an ethical clearance from the Ethics Committee of Mountain University. Third, we obtained a research authorization from the director of Lakentini Hospital. Then we had a meeting with the major of the traumatology service, where we introduced ourselves and demanded access to the patient files and their bed positions. And after that, we had a meeting with the patients where we discussed with them, we obtained their consentment, spoke to them about the machine, and told them about the benefits it may have, and we didn't equally omit the risks it may have by using the machine, because it's still the very first version of the machine. And then later on, we proceeded with data collection, as seen on the pictures, the pictures on the PowerPoint. Data management was performed using Excel 2016. Data analysis and plots were done using RStudio 4.21 and Excel 2016 respectively. Linear regression was performed to determine the correlation between range of motion and pain felt by participants. The confidence level was chosen at 95%, and significance was accepted for any p-value less or equal to 0.5%. Mr. President of the jury, honorable members of the jury, our results which shall be simultaneously discussed. According to our first objective, we were able to identify 7 cases of knee stiffness at Lakentini Hospital, and we divided them into 2 groups. 4 participants which comprised the experimental group, and 3 participants which comprised the control group on which we used the conventional method of physical therapy. They all had knee stiffness after surgery or prolonged immobilization, and the mean age was 39. All participants were men, which surprisingly is in contradiction with the results obtained by Kai and he in a study carried out in the United Kingdom, which showed that the prevalence of lower limb fracture was rather higher in women. Knee stiffness in the traumatology and physical therapy service was due to fractures, was reason for 80% of cases. The experimental group had a higher gain in range of motion as post-operatively than the conventional rehabilitation group, which is in accordance with a study carried out by Anthony Ayotunde and Associates in 2013 in Nigeria on a similar apparatus called arthrokinetic. The same evolution was observed for the cases 2 and 3, at the exception that the case patient 2 skipped physical therapy for 2 weeks, which made his range of motion to drop again, despite the fact that he was gradually progressing. But unfortunately, there is no data recorded on the evolution of range of motion for irregular patients. For the control group, that is case 1, 2, and 3, their curves all behaved in the same manner. That is a slow gain in range of motion and decrease in pain, which is in accordance with a study carried out by Montgomery in 1985. The curves are ascending for all subjects, which shows that therapy was evolving positively and was successful for all 7 patients. Yet the curve for the experimental group was higher than the control group by the end of the study. The patients who worked with the apparatus had a total mean gain in range of motion of 26.3%, and we obtained that value by subtracting the final range the final range of motion from the initial range of motion. And after doing that, we did the same thing with the control group, and the value get 18.3%. This shows that the experimental group gained more range motion as compared to the control group, which is in contrario with the study carried out by Patrick in 2007 in the US. The tables also show that there was no significant difference in pain assessment for both groups at the end of the study. This is in accordance with the study carried out by Shizardi in 2020 in Iran. We also noted that patients who worked with the apparatus at intervals of 1 day healed faster than patients who spaced out their physical therapy sessions. We can say limits of this study. The time of study was too short to properly note the evolution of range of motion. All patients were evaluated equally. All patients did not have the same number of sessions, and we had a small number of patients. To conclude, we can say that knee stiffness was discovered in all the subjects who had undergone surgery in the lower limb and were immobilized for long periods. Post-surgery complication was the cause of knee stiffness in 80% of the patients. Treatment was successful in both groups, but the patients who worked with the apparatus had a total mean gain in range of motion of 26.3%. The control group was 18.3. This shows that the experimental group gained more range of motion as compared to the control group. There was no significant difference in pain for both groups. The patients who worked with the apparatus at a shorter interval, that is 1 day, recuperated the most. As recommendations, we recommend traumatologists to prescribe physical therapy as soon as possible. We equally recommend for the study to be carried out on a larger population to get better results, and for physical therapy to innovate the domain with more instruments to facilitate rehabilitation. We must not always wait for machines from Europe and America before carrying out physical therapy. Honorables membres du jury, notre résumé. La raideur du genou a une sensation perçue d'oppression dans l'articulation du genou lorsqu'on tente de la déplacer après une période d'inactivité. C'est la complication musculo-squelettique majeure post-opératoire d'immobilisation du membre inférieur. Le but de la kinésithérapie après une intervention chirurgicale ou une immobilisation est d'aider le patient à retrouver la fonctionnalité de l'articulation et de réduire les séquelles indésirables de l'intervention chirurgicale. Nous avons réalisé que le positionnement et la mobilisation sont trop exigeants pour les kinésithérapeutes et difficiles pour les patients. Nous avons donc conçu et construit un appareil en bois qui permettra au patient d'effectuer son positionnement et ses mobilisations passives continues en fonction de sa tolérance de douleur. Et nous avons donné le nom SGG MK 1.0 by NWANA. L'objectif de ce travail était d'évaluer l'effet thérapeutique de l'inclusion d'un appareil de mobilisation dans la rééducation du patient avec raideur du genou à l'hôpital La Quintinie de Douala. C'était une étude descriptive réalisée sur une période de 2 mois au service de traumatologie et de kinésithérapie à l'hôpital La Quintinie de Douala. Les données ont été collectées sur 7 patients qui ont été scindés dans 2 groupes, un groupe expérimental et un groupe contrôle. Lors du suivi, les patients ont travaillé à différents intervalles. L'analyse de données et les traces ont été effectuées respectivement à l'aide de RStudio R 4.2.1 et Excel 2016. Les participants ont été sélectionnés selon nos critères d'inclusion, tous les hommes avec un âge moyen de 39 plus ou moins 7. La principale cause de raideur du genou chez les patients était post-opératoire. À la fin de l'étude, le gain moyen d'amplitude de mouvement pour le groupe expérimental était plus élevé que le groupe contrôle, mais il n'y avait pas de différence significative dans la comparaison de la douleur moyenne entre les 2 groupes. Honorables membres du jury, je vous remercie pour votre aimable attention.
Go directly into the next phase, which is the phase of evaluation. Clearly, we evaluate your work.
Thank you, Mr. Professor Agor. I'm very grateful to be accepted near you to evaluate NWANA's work. I'm also very grateful to be older brother, Mr. Phil. My English is very bad, so it is not possible for me to continue in English. If you want me to help me to improve, I'm bound to come back in French. And then you will see that I will be at my ease. Okay? All right. Alors, Monsieur le Président, j'ai découvert le travail de NWANA il y a quelques jours qu'un collègue m'en a parlé. Il m'en a parlé, je n'avais pas tous les détails. Mais d'emblée, j'étais preneur de l'initiative, de chercher à aller vers des productions élevées locales qui permettraient de lutter contre un certain nombre de difficultés que nous rencontrons dans la prise en charge des patients avec des rayures du genou, telles qu'elle en a parlé. Mais comme c'est une œuvre scientifique, je suis obligé de la critiquer pour pouvoir aider à son amélioration. Ma critique n'est pas destructrice, ma critique ne sera pas pour te décourager, mais ma critique sera pour qu'on sorte de ce qu'on voit aujourd'hui vers quelque chose de beaucoup plus perfectionné. Alors, je vais commencer par le début. Je suis sûr que c'est la longueur de l'œuvre qui a fait problème, c'est pour ça qu'on a abrégé dans le titre. Parce que l'abrégation dans le titre me pose un petit problème. Pour quelqu'un qui veut juste lire le titre, il est impossible pour lui de pouvoir appréhender de quoi il s'agit. C'est pour ça que les abréviations ne sont pas admises dans le titre. Il faut tout écrire pour qu'on puisse vous saisir. Mais avec la longueur déjà du titre, je comprends quelle a été votre difficulté. Je viens maintenant dans la partie introductive, la partie qui a signé introduction. Alors, je découvre quand même que tu as des schémas dans ton introduction. Pour moi, c'est inédit. Je n'ai pas. C'est ma première fois de voir des schémas dans une introduction. Je ne crois pas que ce soit totalement approprié. Donc tu as tout le temps dans ta revue de littérature, bien au niveau de la partie overview, pour mettre ça, pour pouvoir mettre des schémas et parler de l'anatomie du genou. Parce que plus tard, tu as le temps de parler de l'anatomie du genou pour pouvoir mettre ça. Mais dans l'introduction, non, ce n'est pas le bon endroit. Et puis le premier schéma des knee joints, tu n'as pas mis la référence. Le deuxième schéma, il vient de toi certainement. Donc, tu n'as pas besoin de mettre des références, mais l'autre schéma, ce n'est pas de toi. Donc, il faut mettre la référence à ce niveau. Tes schémas, ici, je suggère que tu les ramènes dans les généralités. C'est l'endroit le plus approprié pour les schémas. Voilà. Comme tu as fait à partir de la page 15. À partir de la page 15, tu peux avoir le temps de mettre tous tes schémas de ce côté-là. Bon, maintenant, ça c'est des questions, c'est juste quelques questions de forme. On va parler de ce que tu as fait. Qu'est-ce qui t'a amené là?
Merci pour cette question, monsieur l'examinateur. En fait, quand je pars en stage, quand je travaille en stage, mon but ce n'est pas seulement d'avoir des bonnes notes. Je cherche des moyens vraiment à avoir les patients guéris. La preuve de ça, c'est que ça, ce n'est pas ma première invention. Je suis toujours à la recherche d'améliorer la kinésithérapie et faire en sorte qu'un patient ne se sente pas limité parce qu'il est au Cameroun et il n'a pas un appareil qui se trouve seulement aux pays occidentaux.
Ok. Ça, c'est de façon générale. Maintenant, si on vient de façon beaucoup plus précise dans la pratique quotidienne, l'idée de chercher à faire un appareil pour mobiliser le genou vient de quoi? Vous trouvez que c'était pénible pour vous de faire des mobilisations passives manuelles? Ou bien, je veux savoir, je ne veux pas vous suivre de réponse, je veux savoir pourquoi est-ce que vous sentez que c'est une nécessité d'aller vers là?
D'accord. Monsieur, selon une étude réalisée par Edward, il a dit que pour la récupération maximale, il faut 3 à 5 séances par semaine pour faire une bonne rééducation. Mais ici au Cameroun, les patients ne viennent pas au service de kinésithérapie en fonction de ce qui est nécessaire pour eux, ils viennent en fonction de leurs moyens. Donc, si...
Okay. Alors, vous connaissez un arthromoteur?
Oui, monsieur.
Vous avez un arthromoteur?
J'ai découvert après avoir créé ceci. Quand mon encadreur m'a dit, pas faire des recherches pour t'assurer qu'il n'y a pas quelque chose similaire à ce que tu viens de présenter. C'est là où je suis partie sur le net et j'ai vu l'arthromoteur.
Ok. Alors, ce que moi je voudrais dire, si vous n'avez pas vu si ce que vous dites est vrai et que vous n'avez jamais vu un arthromoteur avant d'imaginer votre dispositif, je serais davantage beaucoup plus content. Je dirais que vous avez été extrêmement créatif en pensant à ça si vous n'avez pas vu un arthromoteur. Mais pour faire, votre encadreur a suivi une démarche scientifique basique. Avant de dire que tu as inventé quelque chose, il faut vérifier si les autres ne l'ont pas encore fait avant toi. D'accord? Ce qui est devant moi, ce que tu appelles, rappelle le nom? SGG. Et tu as fait une faute sur le titre du document, tu as mis SGF. Hein? Il faut corriger ça. Alors, excusez-moi, monsieur le président, elle a fait quelque chose, vous allez me permettre de prendre quelques minutes quand même pour qu'on en discute. Alors, vous avez dit tout à l'heure que votre encadreur vous a envoyé fouiller la littérature pour voir si vous n'avez pas découvert autre chose. Aujourd'hui, que vous savez qu'un arthromoteur existe, qui est un dispositif, je dirais, qui est beaucoup plus bien élaboré que ce que vous avez à ce stade. Qu'est-ce que vous dites? Vous dites oui.
Maintenant, j'ai fait mes recherches sur le prix d'un arthromoteur. Le prix d'un arthromoteur, c'est 600 000 en montant. Et imagine si nous devons expédier ça au Cameroun. C'est encore plus d'argent. Pourtant, si on devait utiliser ceci, ça va vraiment aider les patients. Sans parler.
Qu'est-ce que vous pensez que vous pouvez modifier sur votre dispositif pour rejoindre le dispositif, pour être beaucoup plus complet par rapport à la modèle?
D'abord, ceci est pénible pour les patients parce qu'il s'agit de tirer sur cette corde avant que l'appareil puisse se plier. Et maintenant, ceci était pénible pour les patients et en faisant la rééducation, il fallait qu'ils portent les gants. Donc, sûrement, je vais chercher à mettre quelque chose de plus épais ici.
Ok, en dehors de ça.
La matière, le bois est également trop lourd. C'était pas facile chaque fois.
Et vous pensez à quoi?
Peut-être du bois plus léger pour fabriquer une meilleure version.
Ok, venez à la page 38. C'est bon? Regardez comment est-ce que le membre de votre patient est disposé sur le dispositif. Qu'est-ce qui pourrait manquer? Page 38. Tu as ton document, non?
D'accord. Oui, je suis là, monsieur. Qu'est-ce qui peut manquer?
Page 38. Qu'est-ce que vous dites de la disposition du membre pelvien sur le dispositif?
Il y a la partie inférieure du membre est soulevée. Alors s'il y avait moyen de de mettre des cordes pour faire en sorte que le membre reste plus attaché sur l'appareil. Ça va?
En utilisant, vous avez constaté pourquoi vous n'avez pas pensé à ça. Alors, Monsieur le Président, je suis resté depuis le titre, parce que le titre vous pousse forcément à aller découvrir ce qui se passe effectivement avec ce dont parle l'étudiant. Je trouve que elle a pris beaucoup de risques. Elle a pris beaucoup de risques en s'engageant dans quelque chose qui peut être énormément critiqué par nous autres. La disposition du membre inférieur, les limites qu'il peut trouver à ton dispositif. Il n'y a pas du poids, du maniement, de la manivelle, du semblage du membre. Vous n'avez pas passé le semblage du membre est impératif. Si on ne semble pas le membre, c'est totalement inconfortable en termes de douleur. Parce qu'un genou enraidi est un genou douloureux par définition. Sauf si c'est une vieille raideur. D'accord? Et également, la longueur. Est-ce que ça, moi je peux l'utiliser? Est-ce qu'un enfant de 10 ans peut l'utiliser? Voilà la différence entre un arthromoteur et ce que vous avez fait. Je vous recommande de continuer à prendre autant de risques comme vous l'avez pris vous. Allez-y et le dispositif peut être amélioré pour que ça soit beaucoup plus confortable. Et la prochaine fois, vous ferez une étude comparative entre l'utilisation de votre dispositif et un arthromoteur régulier. Ça vous permettra réellement d'avoir d'autres éléments de satisfaction. Monsieur le Président Vigélie, je vais finir en vous disant que depuis que nous surveillons les travaux des enfants, je n'ai pas vu un enfant prendre autant de risques. Elle a pris des risques, elle a fait quelque chose qui n'est pas parfait du tout, mais c'est un gros risque que je salue à ça justement.
Merci. I would like to continue in English. I'm also a member of the so I have to make my own comments. This is innovation. And that is one of the things I will encourage in this university. And when innovation comes, we have to over time. Innovation should continue so that other people different occasions to be able to adapt to the device. So you should make it somehow semi-adjustable. So should be able to adjust it. So I want to start by congratulating you for doing this work. I've gone through the documents. It is well written, just that the police is too small. We are getting old. So our eyes are not very, very good as common. I want to congratulate you for absolutely by your work. Everything is there, except the place where you did your study. Your study completion of the study. The introduction of your work, I did not see what motivated you actually to go into this type of innovation. So you have to put your research in because this is research and innovation. So you have to add it to your work. I don't have much to talk about the objectives because they are very clear. Let's take to identify for having stiff neck and then the other one for solution. One thing that I want to say about stiff neck is becoming very common. You see people who and they are drinking like this, it's because they cannot stretch their muscles again. And it is very, very common. People who are involved in accidents, domestic accidents everywhere. And one of the is why those medical advice because it's expensive. And then you have to pass through security all the time. It's time consuming. And people abandon and eventually they become handicapped. What I want to say about this is cost effective. It is cheap. Yes, it is cheap. The question I wanted to ask you is that can somebody buy a house alone without going to save?
That was one of the ideas behind the creation of this. That for patients who cannot do their 5 sessions of physical therapy, at least if he has the machine at home, even if he does not have enough money to do the 5 sessions, he can come for 2 or 3 and then complete the 2 others at home himself.
Okay, I will go to their picture review very slightly. That's what we have add enough references to show us that we have read enough. The methodology is good, but you do not define your study population inside the book. You have to do that. On that method, you have to describe the study population before you talk about the distribution and the execution criteria. So you have to add that. And the study population falls under the discussion part of the work. And then there are some cases that you presented in your methodology. Some pictures. Are they part of your work?
Yes, sir.
I think those cases are supposed to be evidence so that you can repair from the methodology and evidence. Case 1, case 2, case 3. Social and methodology. Yes, and then you see extra consideration in our work. You know, it's so it's a clinical trial, right? It's a clinical trial. So ethics has to be very important. Clinical trial. The concept of the communication institution. You have to add extra consideration to the
So it's behind the document.
yes. They have to sign, all of them have to sign.
Yes, we all sign.
Yes. And then your sample size is very small. What I would encourage you in this work is that the university gives us shorter period of time to do research. Then I would encourage you that after this research, this graduation, you should continue and get a bigger sample size so that you can actually present the results that can be acceptable in any scientific milieu. Have you understand?
Yes, sir.
The sample size is very, very small for you to conclude that this machine is very effective. We have seen a 25% improvement in because the literature review is short, you can see it in your discussion. You understand? It means that you concentrated more on the technical aspect of your work than the academic. So improve on your literature review. I mean, that will help you to improve on your discussion. In short, in your discussion, I cannot really see one reference. I can only see pictures and figures. Yes. In the discussion, you discuss your results. You discuss your results and you back it up with other studies that have been done. That's it. My conclusion is good. Follow your objectives. So, I don't have much to say about that. I will like to tell you that it's also good for you to improve on your references. And it starts from the literature review, the discussion, and your reference. So that academic aspect of your work that you I will conclude by telling you that we should continue with this spirit. We need innovation, we need things that are cheaper, things that are affordable. And then, one other thing, this innovation is not an innovation of because I've seen more of it.
more than 6 months. And then at the end of the organization, I had airport stiffness. So that I had to and it was also costly. And then so that if she had anxiety, then those after physical therapy, heart, for example, like this, walk again normally as other people. It is a very good idea. Good idea because she was the one who designed it and tested it. And then she told you that when it is only when she designed it that she went back to see the that I know is the first year. She back young people who are very concentrated in a job where she has to provide results. That is what I see from her. Then I have noticed that the member of the jury have highlighted some. That's what we document. And then I assured that we will be correcting that. And then the document that we provided, final document, we have all the so I thank Mrs. Ghana one more time. And then I thank you taking so that examine the job. Thank you.
The comments, it shows that Rwanda is a very hard industry. It's good that you're continuing from Rwanda for Lenka. It's not Italian. Can you explain what you have done to just summarize it in 1 minute. You don't know you're there. Okay, thank you very much. We will not waste your time for you to go out because you have to take that with respect to presence. So we are going to announce the results. Today we are happy to have the work that was presented by Ms. NWANA. Ms. NWANA, an innovation, an apparatus that is used to solve a lot of complex problems. She has tried, she has worked with her co-directors. The work has been evaluated by an expert, and he's very, very competent with the work. There are some minor corrections that we have to do on this work. And we, the members of the jury, we want to appreciate the work that we have been doing. And we expect that at the end of this exercise, we do the correction of the academic work, bring to us to correct. Then we want to congratulate you for the work that you have done for this innovation. with a mark of 95%.